This video is about biceps tendonitis and the treatment of biceps tendonitis to include either a biceps tenotomy or a biceps tenodesis. One of the most common causes of shoulder pain that I see in my office is biceps tendonitis. This can happen in patients at any age. Typically, a patient is going to describe shoulder pain with different movements, and typically an anterior shoulder pain or a pain in the front of the shoulder that typically bothers them with motion, but also can be bothersome while at rest. When you come to my office complaining of shoulder pain, we'll always get an x-ray. This will allow us to see if there's any arthritis or if there's any abnormality with the way the humeral head or the ball of the shoulder is positioned in the socket. If all the patient is experiencing is biceps tendonitis, then typically the x-ray is going to look totally normal. If based on our exam we have concern for biceps tendonitis, typically we'll start with a non-operative type treatment. I usually recommend an intra-articular steroid injection done in the office under ultrasound guidance. This will typically resolve a lot of the symptoms a patient is experiencing for some amount of time. A lot of the time we prescribe prescription strength anti-inflammatories, and we'll get a patient started in physical therapy and see a patient back 6 weeks later. If the patient's symptoms have completely resolved, then no further workup is needed. If the patient only got a few weeks of relief from the injection and then the pain came back, typically at that point I would order an MRI to further evaluate the shoulder. When I order an MRI, specifically I'm looking at the biceps tendon and the way it travels in its groove in the shoulder, as well as looking at the rotator cuff to make sure it's intact and make sure there's no other additional pathology on the shoulder that we were not able to appreciate on x-ray. Once a diagnosis of biceps tendonitis is made, we could always consider a repeat injection to see if the patient gets more long-lasting relief. However, if the patient fails multiple injections or wants a more definitive treatment option, we would then discuss surgery. Surgery for this issue involves removing the biceps from the shoulder. The biceps muscle has two muscle bellies, so it has two tendons that attach up around the shoulder. One of these tendons attaches within the shoulder, and that's the one that's bothersome for patients. The other tendon attaches outside of the shoulder, and that never causes issues for patients. The easiest, most simple option with biceps tendonitis is to simply detach the biceps insertion in the shoulder. The biceps attaches actually into the shoulder socket, into the labrum, which is a ligament that goes around the shoulder. This can be done with the use of a shoulder scope with just a few little poke holes around the shoulder. We can get into the shoulder and visualize the biceps tendon and look for irritation, and this can be released. When the biceps is released and not reattached, this is called a biceps tenotomy. The symptoms that a patient is experiencing will be completely resolved simply from releasing the biceps tendon. Sometimes a patient would like for the biceps tendon to be reattached. This is called a biceps tenodesis. Biceps can be reattached to the humerus in two different ways. It can be done all through the arthroscope and attached in the top of the humerus, or it can be attached at a lower point on the humerus, in which we call a subpectoral biceps tenodesis, in which we are going underneath the pec muscle to reattach the biceps tendon. The main advantage of cutting the biceps and not reattaching it is the patient will have no restrictions after surgery. It's also a little bit less surgery, it's a little bit quicker surgery. The functionality of a shoulder after a biceps tenotomy versus the tenodesis has been studied extensively, and there's no functional difference between reattaching it as is done in a tenodesis versus just cutting it and not reattaching it. The only real difference with the tenodesis is that the biceps has a better chance of maintaining its normal shape. In about 20% of patients in which a tenotomy is performed and the biceps is not reattached, the biceps can change shape and form what we call a Popeye deformity of the muscle. Depending on the patient's body habitus or the size of the patient or their muscular shape, they may or may not notice this change in shape in the biceps tendon. For patients that are very worried about this change in shape in the biceps muscle, that's when we would elect to perform a tenodesis. With a tenodesis, we would have to protect the biceps repair, and so there will be some limitations after surgery. Specifically, I limit resisted supination or resisted elbow flexion for 6 weeks. Furthermore, as a patient moves their shoulder, I ask them to try to keep their elbow bent and not fully extend the elbow, which puts more stretch on the biceps tendon. So it's a little bit of a longer recovery and a few more restrictions after surgery compared to the tenotomy. Either way, the symptoms of the shoulder pain should completely resolve. With a biceps tenotomy, I would consider a patient fully recovered and they should be back to all activities by about 6 weeks post-op. With a biceps tenodesis, it'll probably be a little bit longer, somewhere around 10 to 12 weeks.